Hello everybody. If you're watching this now, I'm assuming you're either about to head out for the holiday weekend or maybe you just grabbed another piece of pie, but hello. You'll notice I've added video of me this time. The last time I posted a video, I had just the PowerPoint display, and I'm not sure if seeing facial expressions as I'm speaking is useful or not. I have a suspicion it's not, but I thought I would do it this way this time, and I'll ask you to just pay attention, see if you think it adds anything, and I'll ask you about it when we all return. I'm just trying to get it right. So when we left off, what we were talking about was biomedical treatments of psychological disorders, and we had focused so far on mood disorders, in particular major depression and bipolar disorder, and we also spoke about biomedical treatments for anxiety. A lot of them were the same, but there were some important differences between them. Some of the pharmacological treatments were the same, but there were some important differences, and there are also added ones for major depression. Also added ones for anxiety. So where we're going to move now is to talk about schizophrenia, which, as we spoke about in class, when we spoke about disorders, we know is a disorder that involves the dopamine system. What we didn't speak about as much is that it also, more recent research is showing that another neurotransmitter called glutamate is involved. What I want to do now is to show you a video that interviews an individual who is suffering from schizophrenia. The video is a little bit dated. It talks about dopamine. It does not talk about glutamate, but it gives the basic idea of what the antipsychotic drugs do, and importantly, gives a view of this individual before and after he went on his medication. And I think it's really important to see the profound difference that the treatment can make. So let me get this started. Uh-oh, it's not playing here. I'm going to have to access it through another. Hold on one second. Let me access the video through another route. I thought it would play while I had this going, but this will work. Okay, let me make it bigger. There we go.
Before the advent of modern antipsychotic medications, most sufferers of schizophrenia were unable to live or function independently.
You seem kind of down today.
Mm-hmm.
Could you share with us something? What's going on in your mind? How you're feeling?
I'm feeling okay. Basically, but mentally, I'm a mess. All I have is thoughts going across my head of all sorts.
Do they make sense?
No.
Garza, is there anything that you'd like to tell us or ask us?
No.
You're about getting ready to change your medications, aren't you?
Yes.
When's that going to...
Forward to that.
You're looking forward to that?
Yes.
I can remember when I was a resident in psychiatry, we had nothing specific with which to treat our patients, except perhaps shock treatment, which seldom helped, or cool baths. We had to tie them into a bathtub under a canvas restraint, and it was a pretty awful situation. I remember that I went away for a year of fellowship abroad, 1953 and 54, and when I returned, the new drug, chlorpromazine, which we knew as Thorazine, had just been made available, and it was the difference between night and day. Suddenly, we had an agent which, while not curing the disease, made it possible for at least some of these patients to be reclaimed, to even live a halfway normal life with their families and in some cases going out to work, so that the field changed enormously at that point.
Antipsychotic drugs alleviate the symptoms of schizophrenia by by normalizing the chemistry of the brain. In the brain, the nerves never actually touch. They're separated by small gaps known as synapses. Chemicals released from one nerve ending attach to the surface of the next nerve ending, causing the nerve to respond electrically. In the case of schizophrenia, there seems to be excessive activity at the synapses that use the neurotransmitter dopamine. Antipsychotic drugs reduce this activity.
Well, it was found relatively quickly that these neuroleptics all seem to act on one particular type of neurotransmitter, the so-called dopamine system, nerve cells which use dopamine as a transmitter, and that they block the receptors for dopamine over here. So that led rise to a theory of schizophrenia, that schizophrenia is a relative excess of dopamine. We don't know if it's a true excess or just in some way or other there's a balance and we're restoring it to normal by blocking the effects of dopamine.
The effectiveness of antipsychotic drugs in alleviating symptoms is shown in Augustine's behavior after 4 weeks on medication.
I'm a patriarch, a doctor of the church, a world leader. Things of that sort.
Fairly grand ideas.
Yeah, I don't have them anymore.
Back then, did you really believe those things? Were you really caught up in them?
I was caught up in them, but I didn't believe I could make it.
You didn't think you'd make it.
Right.
What do you think now? What do you think the future holds for you now?
Work.
Work?
Work.
Very recently, there have been other exciting things happening. Second and third generations of drugs, rather different molecules, have become available. The exciting thing is they seem to have the capacity to help that 25 to 30% of patients whom we never could touch before with the usual neuroleptic or psychotic type of drugs. These drugs seem to work in a slightly different way. They work on different molecules in the brain. We call them receptor systems. And it may well be that by changing the structure of the drug molecule that we're dealing with, we may gradually close in on most of the sick molecular components in the brains of schizophrenics, and eventually we may be able to help all of our patients. But again, I must stress that this is amelioration and stabilization. It's not cure yet, and cure is what we want. In other words, we have to learn how to prevent.
Sorry about that. That was my cat, who you have always seen on my desktop. That's Melman. So, let me go back. These treatments are widely used in schizophrenia patients now, and that second and third generation of drugs that doctor was talking about are drugs that now are in their fourth and fifth and sixth generations. This video is a few years old, and there is a great deal of success, although not every schizophrenic patient today is able to be helped through these medications. There are a number for which the medications are not particularly effective, but there are many folks who live their lives quite nicely. As you saw with Augustine, he was really, he said what the future held for him was work, and he was looking forward to just holding down a job and having a normal life again, which really is the goal. And as you can see by this graph, what we see here are the introduction of antipsychotic drugs here at some point in the 60s. And that was my cat again, I'm sorry. The introduction of those drugs in the 60s and looking at what it did to the rise, the continued rise in hospitalization rates for schizophrenics. We see that as more hospitals are built, as the population is growing in particular, and so there are more schizophrenics in the population, we see it growing from the early 1900s at a fairly steady rate. Once these antipsychotic drugs are introduced here, we see this very rapid decline in hospitalizations here, and that's a terrific thing. So where we need to go now, we've done talking about, we finished talking about the biomedical treatments. The next place to move now is to start talking about the various talk therapies that are available for folks with varying disorders. We're going to talk about a number of them, but before we do, it's really important to talk about the kinds of therapists that are out there, because not all therapists are trained in exactly the same way. There's a lot of variation in the type of academic degrees they have, in the level of education that they have, and so forth. I will talk about each one of these in kind. One thing I will say from the outset is that there's not been a lot of evidence showing that somebody with a PhD is more effective as a therapist than somebody with a master's degree. There are a lot of factors that go into whether or not a therapist is effective, and it's not very strongly correlated with their level of education necessarily. So what are the differences between folks with varying degrees? Well, first of all, as a clinical psychologist, they have some sort of an academic doctorate, either an Ed.D., a PsyD, or a PhD. These folks, like all of the practitioners that we'll be talking about, need to be licensed to practice. So just because somebody has a PhD doesn't mean they're licensed to practice. I have a PhD. I have a master's degree in psychology, a PhD in cognitive science, and I am not qualified to do therapy because it's not my specialty and I've not passed a licensing exam. So importantly, if you do decide at some point ever to seek therapy, you want to make sure that the person you're seeing is licensed. Don't look just at what their specific academic degree is, if they have a PhD. But these folks they go into programs, and they've graduated programs that give them very strong expertise in psychological testing and evaluation. They're very good at diagnostics, and they can work in a variety of settings. They can be in a private practice, they can work at a hospital, and so forth. A psychiatrist is trained in a medical school. They actually are medical doctors. They have medical degrees, but rather than specializing in, say, cardiology or oncology or pediatrics, they have specialized in psychiatry. And they're trained, like the clinical psychologist, to do psychotherapy. The psychiatrist has a particularly important role within the field, because our laws are such that only a medical doctor can prescribe medications. So even a clinical psychologist in most states cannot actually prescribe medications. There is some movement to change that. There is some licensing in some states with further training to allow clinical psychologists and some of the other specialists to write prescriptions. But for right now, and particularly importantly in Massachusetts, only a psychiatrist, a medical doctor, can prescribe medications. A psychoanalyst is usually a psychiatrist or a clinical psychologist, and they have received specific training in psychoanalysis, which is Freudian psychotherapy. So we've spoken about that when we spoke about dreams, the Freudian view of dreams, and we spoke about the Freudian view of personality. And we spoke about all that entails. We'll be talking about particularly what the psychoanalytic approach to therapy is, but you pretty much know it already. We spoke about it a lot when we spoke about personality, the different techniques that Freud used. And you actually know a fair amount about that already. But these folks are trained in that particular school of thought, the school that was originated by Sigmund Freud. Now, a licensed professional counselor does not necessarily hold a PhD or an MD. A licensed professional counselor usually holds at least a master's degree in counseling, and they've undergone very extensive training and supervision. They've done placements in counseling and are trained in a variety of therapy techniques. Again, these folks need to pass the state licensing exam, just like any of the other specialists do. A psychiatric social worker holds a master's degree, but rather than in counseling, they hold a master's degree in social work. And these folks may or may not have particular training in psychotherapy, but they usually work for social service agencies and so forth, although they can be in private practice, and they may have gotten training in psychotherapy. A marriage and family therapist usually holds a master's degree as well, usually with extensive additional training in couples therapy or marriage counseling, and we'll be talking about that in a little while. Actually, we'll be talking about that in class within a week or so. Finally, a psychiatric nurse is an RN, a registered nurse. They've passed the state licensing exams to be a nurse, but they have selected psychiatry or mental health as their specialty in the same way that a medical doctor may have chosen psychiatry as their specialty. They typically work in hospital settings, although they can work in community mental health settings as well, and they may or may not have training in psychotherapy. So if you are ever in the market to find yourself a therapist, you may find folks with any of these credentials. The important thing is that if you're looking for individual counseling, to make sure that they're licensed by the state and that their license has been kept up to date. So given all of that, all of these different folks, what kind of talk therapy might they be using? What type of techniques might any of these folks be using should you seek counseling from one of them? Well, first we'll talk about psychoanalytic therapy. This is based on Freud's theory, and as I already mentioned, we've spoken about this quite a lot. This is based on Freud's personality theory, and it employs the same strategies that were pioneered by Freud, and we spoke about these at length when we spoke about the Freudian view of personality, and I had spoken with you all about, well, how did Freud come up with this theory of personality? And the idea was that he had developed these techniques, he thought about the unconscious, and the idea was that he wanted to get into the unconscious of his clients in order to free up whatever the issues were, to bring them out of the unconscious, to have them emerge into the sunlight so that they could be dealt with in a healthy manner and stop affecting the individual's personality in ways that were harmful. So the idea is that if somebody is experiencing psychopathology, that there's something going on in the unconscious that's causing the problem, according to the Freudian view, and the Freudian therapist's goal is to bring those issues out into the open and thereby ending the psychological pathology. So the therapists use the same techniques that Freud used in his office: free association, just allowing the client to speak, letting one idea lead to another, and hopefully leading to issues in the unconscious. Dream analysis, remember Freud said dreams were the royal road to the unconscious, and that was his way of trying to figure out some of the content of the unconscious. Hypnosis, getting the client to relax and allow information in the unconscious to be accessed while under a hypnotic state. And then also those projective tests. If you remember, we spoke about the thematic apperception test and the Rorschach are both ways of presenting ambiguous images that would allow the client to try and interpret them, and the idea being that issues within the unconscious would be projected onto the interpretation. So the goal is to find the unresolved conflicts in the unconscious that are causing the problems in the present, and to bring them out in the open so they could be resolved. So the therapist listens without interrupting, often for many, many sessions before ever saying a word, occasionally offering insight. In other words, saying to the client, you know, the way you're talking about these issues with your boss sounds an awful lot like the way you used to interact with your dad. Could it be that you are having, there's something going on in your unconscious with your dad that's causing you difficulties with your boss and thereby causing you the anxiety you're feeling around work? That's just an example. So the idea is to occasionally offer some insight to allow the client to try and pull these things out into the open and resolve them. An important component of the therapy is something called transference. And what will happen in transference is that the client will unconsciously, not on purpose, but unconsciously act out an issue in one's early life in sort of a symbolic way with the therapist. So the client may become, for example, very angry with the therapist and begin to act out in an angry way with the therapist. And while you might think, well, this is not good, being angry with your therapist, the therapist actually views this as a very good thing, because this is evidence of transference, that perhaps the anger that the client is feeling towards somebody in childhood is now being played out with the therapist. Now the therapist can sort of bring this out and get the individual to respond to the therapist in a healthy way, learning how, sort of reliving in a symbolic way these kinds of conflicts, and learning how to move through them. So part of what the therapist does, actually, by not responding for all of those sessions and remaining silent, is to try and bring out these issues with the client so that transference will happen. As you can imagine, this takes a really long time, so the therapy typically requires a lot of visits, between 3 to 6 times a week, often for years, in order to see all of this kind of play out, and to work out all of the issues and to get them resolved. As you can imagine, not a lot of people can afford that. So while this therapy is definitely conducted with clients today, it's usually people who have the money to do that. Insurance policies typically, while they're required to cover therapy, usually won't cover several visits a week for years. So partly in response to that, but partly for some other reasons, what's more common today is dynamic therapy, which is a much more modern Freudian therapy, and it's similar to traditional Freudian therapy, psychoanalytic therapy in some ways, but very different in other important ways. As I said, it's more common today, and while it's based on Freud's methods, the insight is offered very early on. The therapist tries very quickly within the first sessions to offer some insight, kind of hastening this process of trying to bring out the things in one's past life that might be interfering with happiness today. So it lasts a few months rather than years, so it's more likely that insurance will pay for it, and even if it doesn't, it's more affordable to the individual. The therapist, like traditional psychoanalytic therapy, uses interpretation to help the therapist identify feelings and transferences that may be present in his or her life. In other words, not necessarily waiting for transference to happen in the office, although it might, but noting, you may be acting towards your boss in the way that you did towards your father, acting towards your wife as you did towards your mother, in order to try and bring these issues out. There's different ways of practicing dynamic therapy. One popular type today is interpersonal therapy, ITP, and ITP focuses on current relationships. So it's very different from traditional psychoanalytic therapy in that it's really not focused on the psychosexual stages and the conflicts that might have happened when you were 5, but instead to look at today's relationships and to look at how those relationships are causing us stress and anxiety and causing pathology. It is similar, though, to the psychoanalytic approach, the traditional Freudian approach, in that it does recognize the importance of childhood experiences. For example, trauma in childhood may have caused a particular type of reaction, sort of a heightened level of emotional response in the individual that may be seen across the board in today's relationships, and bringing out the fact that there was this trauma that causes the individual to be on a heightened state of alert, to be a little hypervigilant in one's relationships, for example, may be an important means of understanding current patterns of behavior. So, if an individual was neglected during childhood, for example, that may cause worries about abandonment and a clinginess to, in today's relationships. So the childhood is considered important like it is in traditional psychoanalytic therapy, but not in the same ways. There's a greater focus on today's relationships. So that's pretty much what I want to cover on the Freudian view. Where we're going to move now is to talk about humanistic therapy. And this one is based on a different personality theory that we spoke about. It's based on Maslow's theory of the self-actualizing person. And if you recall, Carl Rogers built on that and wrote about the person-centered perspective. So it's based on the humanistic personalities perspective that Maslow had pioneered. And so if you recall, there was that hierarchy, that pyramid with basic physical needs at the bottom, and then working up to belongingness and love needs and so on and so forth, with self-actualization at the top. And this is based on that model. And it takes as part of its premise that all patients coming into the office are endowed with the drive to become self-actualized. And so the game for, well, not a game, I shouldn't belittle it in that way. The goal for the therapist is to help the client build self-fulfillment by helping the individual grow in self-awareness and self-acceptance. And if you recall, those are all traits shared by people who are self-actualized. Now remember that Rogers had stipulated the 3 conditions in one's environment that are necessary in order to become self-actualized. Those were genuineness, acceptance, and empathy. So the goal of the therapeutic setting is to provide those conditions for the therapist to be accepting, genuine, and empathetic. And within that setting, to allow the patient to explore his or her own path, his or her own feelings, in order to become self-aware and self-accepting, and to resolve the issues that are maybe preventing that from happening. So the focus then is on the present and awareness of one's feelings in the present. It's on conscious material. So in that sense, it's similar to the more modern dynamic therapy in the Freudian view, but the therapy differs in a very important way. The therapist will never offer insight. The therapist will never try to offer any kind of interpretation, will never point out transferences. Rather, the therapist is there to facilitate the client coming to his or her own insight and recognizing that on her own. So the therapist is very non-directive and uses active listening. So the therapist will use only a very sort of small repertoire of responses to the client specifically. Active listening will entail the therapist seeking clarification. So the client may say something and the therapist will say, "Can you explain that further? Can you go into more detail?" Seeking clarification. Or, "Did you mean this or did you mean that?" Also, the therapist might restate. So the client might say, "I'm feeling so sad today." And the therapist might say, "Oh, you sound a little bit depressed. I hear you saying you're depressed." So that's just a restating. Or maybe just echo it, say it verbatim. So the client might say, "I'm feeling so sad today." And the therapist would say, "You're feeling sad today." Also acknowledging expressed feelings. When the client says, "I'm feeling this way, I'm feeling sad," the therapist might say, "I hear what you're saying. I hear that you're feeling sad." Just acknowledging that. Notice that by doing this, the therapist is not offering information to the client, is simply echoing or reflecting what the client is saying, or getting the client to think further about what he or she is is thinking and feeling. So just to give you a sense of this, I'm going to read you a little bit of a transcript from an actual therapy session. The client comes in and says, "It's just the same old story. Mothers and fathers try to tell kids what to do, and the kids revolt." This is a teenager. "So that's the only thing right now that's between my parents and me." And the therapist says, "So I guess you're saying this is true in general, but it's also true of you, that your parents try to tell you what to do, and you feel, I won't take that." So here the therapist is restating. And the client says, "Well, I don't feel it. I say it, of course. What I say and what I do are two different things, though." The therapist replies, "I'm not quite clear there. You say it, but you don't really feel it?" So here's the therapist asking for clarification. The client says, "Well, put it this way. If my mother tells me what to do, and whether I like it or not, I have to do it. But boy, I let her know I'm not too happy about having to do it either." And the therapist says, Are you saying there she may be able to make me behave in certain ways or do certain things, but she can't control the way I feel, and I let her know how I feel?" So again, restating, but also asking for clarification there. So the idea here is that the therapist is simply acting sort of as a conduit. The philosophy, remember, is that we as human beings are endowed with the drive and the ability to become self-actualized. And this is what the therapist is really geared toward doing. Now you may think to yourself, I don't know if this would work for me. This doesn't seem quite, there's no content here. What I can tell you is that there was a terrific computer program that was written, I think in the 1970s, called ELIZA. And volunteers were asked to come in if they were having some mild issues that they wouldn't mind talking about, to test a new kind of therapy. And the people who volunteered were simply told that what they were being asked to test was doing therapy via early computer chat. Really, they were supposed to type in the information into what they wanted to say to the computer, and that a therapist would be in another room chatting back with them. What they didn't know was that there really was no human therapist. It was a computer program that was taught to do active listening. So the person would type in, "I'm feeling really depressed," and the computer would type back, "Tell me more about that," or I understand that you are depressed," things like that. And they went back and forth, and the patients afterwards, the volunteers, did indicate in follow-up questionnaires that they were helped by the sessions. The volunteers were then told that there was no actual human therapist, that this was a computer program. And very interestingly, what they didn't anticipate was that some of these individuals came back later and asked if they could use the computer program some more, because they found it really useful to engage in this kind of dialogue with themselves, being prompted in that way. So many people actually do find that a useful exercise. So, where we're going to move now is to cognitive therapy, which is among the more common therapies done today. The humanistic therapy is still conducted. It's not as common. The dynamic therapies, the cognitive therapies and behavioral therapies that we'll talk about in a little bit are very common. But there are multiple kinds of cognitive therapies. The basic premise behind cognitive therapy is very straightforward. The idea is that our thinking directly affects our feelings. So the general goal then is to teach the client a more constructive way of thinking, right? So if the way that you're thinking about things is causing the problem, then, the Apple slogan, the Apple computer slogan, "Think Different," really is the key to it. There are two common approaches to cognitive therapy. There's Ellis's rational emotive therapy, and there's Beck's cognitive therapy. Ellis's is less commonly practiced than Beck's, but it is one that is still conducted today. what I want to do is to talk about each of those in turn. The differences between them are actually a bit subtle, but there are important differences nonetheless. In Ellis's rational emotive therapy, as I said, the basic ideas in all cognitive therapies are that the way we think about things is what changes our feelings. So the common sense view, what it looks like from the outside, is we have an activating event, such as you being passed over for a promotion at work. And then there's this consequence. You're miserable and depressed. And it's looking like this activating event is directly causing this consequence. What the cognitive therapies say is that there is a hidden intervening event, which is the beliefs, and that's why it's referred to as A, B, C. In between the activating event and the consequences are the beliefs. And it's these mistaken beliefs, these problematic beliefs, that are the actual cause of these consequences. So one problematic belief that an individual might have in a situation like this is, I must be successful at everything I do, or I'm a complete failure. I wasn't successful here, so I'm a complete failure. I'm a worthless human being. And a lot of us have those kinds of beliefs. Well, I should say all of us have these kinds of beliefs. They're going to vary between people, but we all have ways of thinking about things that cause us distress, that are not helpful. Some more so than others, and this is when it can become very problematic, or maybe the beliefs are just very strongly held and really cause a lot of problems. So behind therapy is to change the beliefs, to change this intervening component. So Ellis's rational emotive therapy says that it's the irrational beliefs that are causing the problem, and it's the irrational nature of the beliefs that are very important. So that's going to be contrasted a lot when we talk about Beck's cognitive therapy. It's important to remember that this is the important thing with for Ellis, is the logic or the rationality behind the beliefs. So the goal of the therapist in rational emotive therapy is to identify what the irrational beliefs are, and then to dispute or challenge those beliefs. So rather than supplying warmth and empathy like you would find with a humanistic therapist, the therapist is often quite blunt, very blunt actually, in rational emotive therapy, and uses logical argument to get the client to recognize the irrational beliefs. Rational emotive therapist, Ellis in particular, was known to swear when he was in session with his patients. He would sometimes, call them names or tell them what they were thinking was stupid. But let me just give you a short example here. The therapist says the client is expressing a belief that if they didn't get the promotion that they were looking for, that it would ruin them. And Ellis says, you just said it would ruin you if you don't get the promotion. That's stupid. Would it really ruin you? That doesn't make any sense. Isn't it more rational to say it would be better to get the promotion? But you don't get it, so what? You dust yourself off and you move on. There's no value in being a wimp and whining about it. So he's being really very blunt here. I mean, he's called the client's beliefs stupid. Okay, he's saying you're irrational, and I'm going to call you on this. Just to give you, I have a bit more transcript here from a different client. It's a similar kind of thing. The client is talking about having a problem with procrastination, and Ellis says, okay, well, when you procrastinate, what do you tell yourself to make yourself procrastinate? I know, see if you know. And the client says, I don't know, I really don't see why I don't do the work. Sometimes I just sort of say I must do other things, like clean my room and so forth, but it's always on my mind. Ellis says, why don't you first do this thing and stop the procrastination? What stops you in your head? I don't know, I guess too much thinking about it, or just go to sleep because I'm tired and I need to be rested in order to write something. And Ellis says to him, those are excuses. What's the real reason you procrastinate? If I push my ass right now, what? And the client says, I don't know. If I push my ass right now, what are you telling yourself to stop yourself from pushing your ass? I told you he uses strong language. I think I'm actually pushing my ass. It's just that it's not effective enough. I don't do the immediate tasks. I do other tasks. And so this kind of goes on, and the client eventually says, I really want to get it done very well, so I sort of don't get to it, or I research it, but I don't actually write the paper. And he says, well, that would be nice, but why must you do it well or perfectly well? Why must you? The patient says, at school I'm involved in many clubs, so I'm considered something of a leader. So I guess I have to do things well. I have to uphold a reputation. And Ellis says, say very strongly, I'd like to do things well, but I don't have to. Say that. And it kind of goes on. The important thing here is that what Ellis is trying to point out is it's irrational to think, I have to do well. I have to be perfect. I have to be all of these things. And what Ellis is trying to point out is it would be better, yes, it would be better if you were successful. It would be better if you were a good role model. It would be better if you wrote the perfect paper. But it's irrational to think that you have to be perfect in this way in order to succeed. So he's really getting his clients to get comfortable with, all right, it would be better if this was perfect or if this were true. But it's really okay if it's not. It's really okay if I don't get the A, or if I don't get this promotion. So he's working very hard to get his patients to recognize the irrational nature of their beliefs. Now, with Beck, it's the same. Notice this is exactly the same common sense view. The activating event is causing the consequence. Beck is also, like Ellis, saying, like all cognitive therapies, the problem is not actually the activating event. It's the intervening hidden mental thing that's causing this consequence. And again, the same kinds of things. I must be successful at everything I do, or I'm a complete failure. So with Beck, the framework is the same. The underlying philosophy is the same, but the details are what is different. Beck believes that psychological distress comes from unhealthy thinking patterns, just like with Ellis, but he doesn't focus on the irrational nature of the client's beliefs. Instead, he focuses on the distortions of thinking and the unrealistic beliefs. So the goal of this therapy is to get the client to recognize that the way that he or she is thinking about things may be harmful. This negative way of thinking about things is causing a problem. And then rather than focusing on the irrationality of what the patient is thinking, and to kind of bring this out in a very strong, in-your-face, forceful way, instead what Beck's interested in doing is to do some testing, some truth testing with the client, and to get the client to recognize, these beliefs I'm holding are untrue. So forget about whether they're logical. It's just, are they true? So in this example that I have here, Beck in response to the client who's saying that they would be ruined if they didn't get the promotion, says, okay, you just said it would ruin you if you don't get the promotion. Is that true? Would it really ruin you? Certainly it would be better to get the promotion, but if you don't get it, will the rest of your career disappear? It's not really true to say that you'll be ruined, is it? Right? So in other words, would there be another opportunity for career advancement in another way in the future? For example, to get the client to really think through whether or not this really is the end of the road. They would be ruined, their career would stop, they'd end up out of a job or so forth. So they are similar, Beck and Ellis's approaches, but Beck was not quite as in your face, and rather than looking at the rationality of it, but really trying to just do some testing. What we do see is that cognitive therapy in general, focusing on the the intervening thoughts that are actually causing the emotional distress is very, very effective in the treatment of depression. What this graph is showing, these are data from 1986, so it was shown very early on that the cognitive therapy is really very effective. These are pre-therapy scores on a depression inventory. We see that the control group scored, roughly 24 and 26, 27, respectively, on this test. And then we have a group that was on a waiting list, waiting to get accepted into the waiting for a spot to open up in this treatment center. And we see that after the trial was over, they did not go down very much. They went down from an average of 24 to about 21 or so. Whereas the individuals who were trained to think differently, who were trained to recognize the negative thinking, the problematic thinking that was causing the problem, and to think more like non-depressed people, to take credit for good events and by not taking all the blame for bad events and so forth, their depression dropped dramatically from a mean of about 27 to about 11, and that was a significant decrease. So we do see that the cognitive therapies can be very effective, and in particular very effective for depression. Where we're going to move from here next time, when we meet again in class, is to talk about behavioral therapies. And there are quite a number of them. We're just going to talk about a few of them. But importantly, one type of behavioral therapy is actually called cognitive behavioral therapy. That is actually a combination of cognitive therapies and behavioral. And the idea is to not just change one's thinking, as we see here in the cognitive therapies, but to also combine that in a change in one's behavior. And the idea being that changing both will really bring about some important changes in an individual's life and in the problems that are causing them distress. So this is all I'm going to talk about for right now. I hope you're enjoying your long weekend. I hope you ate too much on Thanksgiving, or if you're watching this before Thursday, that you will eat too much. Please drive carefully if you're traveling, and I will see you all when you come back.